My presentation is going to be about, it's titled initially in your program as Major Incident Management and Support, but I rephrased it into looking at strategies to address disasters and emergencies, now that we've gotten a good background of what is going to happen or what most likely will happen. In my presentation, I'm going to talk about different strategies, both structural, administrative, and professional as well as clinical, that can be used to address the issue of the burden that we've already observed. So from the beginning, I tried to get us the context of what it is we're dealing with. There are different kinds of problems. At first, you can have a problem which is simple. A simple problem can be something like making a cup of tea. Basically, get sugar, get some water, stir it, and you have tea. That's a simple problem. Very easy solutions, very easy outcomes, and very direct outcomes. A complicated problem, on the other hand, is something that has different parts, but once you get those parts together, it becomes very easy to do and can be done routinely, such as driving a car. If you know how to start the engine, you know how to which pedals work, you can drive the car very easily. Now, a complex problem, on the other hand, is something which does have clear problems, but of which whose solutions are not necessarily obvious. Best example is raising a child. I don't have a child, but I know that raising a child each day has different challenges, and you learn as it comes. So my question to you, to us all, is developing a system that can respond to these issues. Of the three, is it a simple problem, a complex problem, or a complicated problem? Depends, think about it. But I think it's a complex problem. We know the problems, they happen, they will always happen, but the question is, how do we create a system that can respond to these issues? So, with that in mind, we're going to talk about this. So, in this I'm elucidating what emergencies are, what major incidents are, what disasters are, and then what kind of systems can respond to these things. We've used the words emergency, major incident, and disaster interchangeably, but they have different meanings. Then finally, we'll look at some proven methods, such as developing a major incident plan, management plan from the top. So we'll start by understanding what an emergency is. And this quote was made by one of us, Dr. Olive Kobusije, who said, emergencies will occur everywhere, and each day they will consume resources, regardless of whether or not there are systems capable of responding. So this has been true and will continue to be true. Our task is to do something about it. And just last week, the director of the WHO made this quote when he said, no one should die for the lack of access to emergency care, which is an essential part of universal health care. No one should die, because we know it and can predict. So the question is then, what is an emergency? WHO, as well as WHO, tries to define it as an acute injury or illness which poses an immediate risk to someone's life or long-term health. So when we say emergency, that's what we're talking about. A medical emergency is something that has risk to life or long-term health. We escalated now to what a major incident is. We have the daily emergencies that we handle every other day. Then it can be escalated to a major incident, which is defined as an incident where the number, severity, type, or type of live casualties, again, we look at those that are alive. The ones that are dead are not necessarily ones you can salvage, or by its location, requires extraordinary resources. An incident which requires extraordinary resources based on the number, severity, type, and severity of the live casualties is defined as a major incident. Major incidents have to have impact on the community, especially on the health aspects of the community, such as what happens if there was an outbreak of cholera within the capital city or in a district. And there has to be a disruption of health services that are currently routinely normal. They've been classified in two categories. You have category one, which is a compensated major incident, something which is controlled. There's probably an outbreak. An outbreak is declared today. Within 2-3 days, the health services are able to control it, resources are rearranged, and you manage it. That is a compensated major incident. On the other hand, if it stretches longer than that, and the resources currently are not enough, and you need more people, more personnel, more resources, then you get an uncompensated major incident. Now, it can escalate further to when an emergency suddenly is uncompensated and is affecting the system grossly, such that you need resources from what is there, you get a disaster. So incidents such as the boat cruise, would it be a major incident? A disaster. Would the incident in Bududa be a major incident or disaster? Correct. So a disaster is an occurrence which disrupts the normal conditions of existence and causes suffering that exceeds the capacity for adjustment. Our hospital here can adjust quite well to most incidents, but something that would grossly affect the system's ability to pass its adjustment is called a disaster. Now all of these happen and continue to happen. As we've gone through, grossly there are two categories of major disasters: those that are have natural causes, and those that have human causes. We unfortunately get affected by all of them. The natural causes, as you've seen, they can either be sudden, where it was unpredicted and it happened instantly, such as an earthquake, or they can be progressive, such as epidemics, an epidemic or a drought. So different measures are required for those different classes. For the human causes, again, there are sudden causes, then there are progressive causes. The sudden causes, such as major road traffic crashes, are caused by human error. The progressive ones, such as protracted wars, also happen, but are less frequent, but we've had history of that too. So when we're trying to prepare, we're preparing for all four categories. Preparedness is what you do now that you know the problem. How do you prepare to solve it? So anything taken in anticipation of an emergency, major incident or disaster is preparedness. So that's part of what we're trying to discuss today. How do you prepare for what I've just shown you? So emergency care systems are put in place to address this problem, as has been highlighted. And an emergency care system is that organizes all aspects of care provided to patients, straight from the scene of incident or injury or illness, all the way to hospital transportation to the hospital, and is incremental. Care is supposed to increase as you move from the community all the way to the hospital. What I want to note here is care has to start from the community. Most times care starts in the hospital, so a lot of lives are lost in there. This just shows you the chain of survival is very clear there, but to highlight the need for continuation of care, straight from the person who started the care at the community level all the way to the hospital. Care has to go through uninterrupted for best outcomes. Now, with that in mind, the WHO developed a framework for an emergency care system that can ensure that care will be given all the way from where it starts through transportation all the way to the hospital. So that's the emergency care system that can address the problems we have shown. To go through it very quickly, there are three levels. There's the community level, transport, as well as facility-based care to address any event that is a threat to life or limb. The event can be a non-communicable disease, such as a cardiac arrest. It could be a road traffic accident resulting in injury. It could be maternal child emergency or pediatric. So emergencies are cross-cutting. If an emergency does happen at the site, there has to be someone who notices there's an emergency, gives first aid and calls for care that can come and support. For that to happen, there has to be a universal access number to call for help, of which then a provider or ambulance is then sent to give the care, which you see there. If need be for care to go on into the hospital, there has to be a transport mechanism that transports the person safely to the hospital with a provider as well as resources. And at the hospital where we come in, there has to be a handover of patient from the pre-hospital scene to the hospital. In the hospital then we finally have hospital-based emergency care, which then handles the clinical care and definitive care. There have been several gaps on how this is being done, because most of the assumption is to say that all going to be done in the hospital. We realize that we have very few designated emergency units. There are not many people who are permanently based in the emergency units, and we don't have standard ways in which care is given or documentation of care in the emergency areas. And as well, there's a scarcity of equipment to give emergency and acute care. So in summary, that is the emergency care system that we talk about when we talk about response to those issues. The WHO last week developed the Global Emergency and Trauma Care Initiative that is going to create a drive for countries to develop systems to implement proper emergency care. And it has 4 priorities: national interventions, community level interventions, pre-hospital interventions, as well as hospital interventions. So it's a very, very extensive piece of work. But for that, just to highlight, for the national interventions, at national level, the Ministry of Health are expected to do the above, assess their capacity, develop policies, financing strategies, human resource capacity building, as well as infrastructure and national level guidelines, which will trickle down to the rest of the community. Good thing Commissioner will make some comments. Uganda has already done a systems assessment of the capacity for emergency care and is on the way to develop a national policy for emergency care. So that work is already underway. And the School of Public Health as well surveyed select hospitals in the country about their emergency care. We'll now go into some priorities or strategies that can be done to implement that NRP done. We'll start from scene care. From scene care, we talk about care at the community level. Right now, there's very minimal care that is designated or recognized at the community level. But something that can be done is training lay first responders in first aid, as well as creation of laws that protect those people who are trained to give care. So if people are trained in first aid, there has to be a law that allows them to actually give care. They're not health workers, but they're giving care. So legislation has to be put in place to do that, as well as utilize all the people that are actually in the community. They could be the police, they could be firefighters, they could be border people. So anyone who's first on scene should get some training in order to recognize and start care. For pre-hospital emergency care, which is ambulance services, we need to start seeing professional ambulance services of people that are trained, whose job day to day is to provide ambulance services. To do that, enabling components include an ambulance short code, such as what we have for the police, which is 999. There has to be an ambulance number. There have to be standards for vehicles, equipment, and clinical protocols as well for those professionals. What has been done so far, and Commissioner will make mention of this, there's a national EMS code that's been in the offing. I will not say much about that. And there's work to develop call and dispatch centers. Call and dispatch center looks something like that. That's in KCCA, where there's a call and dispatch center that is being piloted. And then hopefully one day we'll have something like that. I looked for pictures on the internet for Uganda, but there are not so many. But hopefully we'll have call and dispatch center that can centrally work on that. That's just a picture during some discussions at KCCA around mapping the capital city and knowing exactly where the hotspots are and trying to test out ambulance services. In terms of specifications, we need to design standards for ambulances that move around, both advanced and basic. And then for the professionals, they have to be designated ambulance professionals who will do the right job. So training and identification of this personnel is important, as well as agreeing that there has to be care started at the community level. So it's site care and events care should be done. With that, there can be safe transportation of these people to the community, to the hospital. So Commissioner will make mention of this as well. Professionals have to be developed for pre-hospital care with very clear scope of practice. Masaka region has been able to start piloting emergency services, Ministry of Health, and have plotted what facilities are within their range, what black spots exist in their region, and what dispatch centers or dispatch points for ambulances can be created there. That's just one region in the country. Hopefully this can be national. They've also created an inventory of EMS providers, both public and private, as well as health services and para-health services. We go now to health facility capacity. Health facilities develop their capacity. They have to assess where they are. They also have to introduce some essential practices such as triage, standardized patient care, registries that detect and compute the numbers of people they're managing, as well as clinical protocols. So luckily there's a WHO assessment tool that hospitals can use to assess their internal capacity for their emergency areas. As well, there's certain guidelines on how to introduce specifications at the hospital level. So assessments can look at infrastructure, they can look at diagnostics, as well as look at point of care resources, and finally human resources. By emergency care, we mean multi-discipline teams. So assessing how many people will be available to give care is extremely important. So looking at how many people in the hospital, for example, Mulago, are there in the emergency unit, how many are fixed, how many can rotate, how many can be called on in the event of an incident is important. Standardized clinical care, so some standards on how to give care at a minimal level, as well as patient clinical forms. Ministry of Health has already developed indicators, Commissioner will mention this, on emergency care, which will give us a more up-to-date look into how we are responding to the daily emergencies. In terms of infrastructure, standardizing our workplaces is critical. So we have standards for emergency units, just like we have standards for intensive care units and other specialized units, with standards on staffing, diagnostics, and equipment, which can be applied across all hospitals. Simple things such as triage and patient and layouts are extremely important. So that's just a slide that showed a layout that was done by the Uganda Hospital in their emergency unit that laid it out in a standard way. Hopefully some hospitals can also adapt. Talks about majors areas, minors areas, as well as the layout in relation to the nurses and doctors' stations, emphasizing resuscitation points. Now, the final thing is about human resources. Systems are only as good as human resources behind them. Different models have been shown on training human resources, starting again from the community all the way to transportation to hospitals. So that just shows you possible range of care that can be given if people are trained at all those levels. WHO has a short course in emergency care, but more sustainably is developing the structures that exist. So training, introducing emergency medicine into the existing training programs as modules, course units, or more robust masters in emergency medicine or critical care or emergency nursing, specialist training programs, also help develop leadership for that. Now, in summary, those give you the basics of an emergency care system that can handle the daily routine emergencies. When you go back to what we decided was a major incident and a disaster, those have to be in place for you to be able to handle something that is overwhelming. So for major incidents, if those processes are in place, the following things have been shown to improve the outcomes following major incidents. Having hospital disaster plans, where hospitals sit together and create plans for the different categories of disasters, is extremely important and has helped reduce the morbidity afterwards. Hospital disaster committees that are designated and activated whenever there's a major incident. Hospital response teams that can be called on both for internal major incidents and external major incidents. Linkages with all the providers in the health services. And finally, communication processes and supplies and equipment for major catastrophes. Some hospitals do have them and they're documented. Whenever an incident happens, they are activated and they help. So what would happen in the event that we were told that there was a major incident that has happened right now? First, there will be a meeting by the committee that hospital has set up a committee. The committee will be activated to meet and discuss and roll out the disaster plan. The disaster plan would have been designed to respond to all these possible disasters. And this committee would have multiple disciplines to either respond to a major incident within the hospital or something external. If there would be need for people to be sent out to respond, they can respond as a team to the event. If not, they can also respond internally. So that just shows you some of the things that can be done. And finally, the response itself can be summarized in the following ways. There has to be command and control, people who are in charge and communicating at all levels. Safety considerations for those that are responding, continuous communication throughout the incident, assessment of what is being done and the impact of the disaster and what should be done, as well as triaging in the event that you had multiple people coming in. And finally, treatment and transport. So in summary, I attempted to take us through what the emergencies are, major incidents, a system that can address both the daily emergencies as well as extraordinary, and some of the things that can be done to address that. Thank you very much.